Hello, everyone. Welcome to Management of DRTB and Diabetes mellitus. So in this module, we are going to look at when you have a patient with DRTB and diabetes, what are the challenges and how do you manage such patients? I'm Dr. Abel Craig Modiba, who's going to be taking you through this module. Now, just to remind you that diabetes mellitus has got relatively, there's a lower immunity in these patients because of this condition of diabetes. It lowers the immunity of the patients. And since because the immunity is lower, these patients are 3 to 5 times more likely to develop TB because of decreased immunity. And it may be more difficult to diagnose TB in these patients because they might have your atypical chest radiograph picture, where it will not be your expected picture of cavities. And most of them develop extrapulmonary TB, not your typical pulmonary TB. And some of them may have worse outcome of TB treatment when they have diabetes. So you need to be aware of them. More likely to suffer drug side effects because both diabetes and TB, they have overlapping toxicity, which we'll talk about. And they might have complication because both of them have an impact on the kidney. And then also in terms of the side effect, they both can cause, some of the drugs, they can cause a neuropathy or those illnesses causing, on their own, causing neuropathy. Now, this looks at in terms of the effect on clinical presentation and treatment resulting from interaction between diabetes and TB. So they were observed, especially in HIV and TB. So the TB risk group, they looked at in terms of the relative risk of developing TB. So they look in terms of your control population, regardless of the PPD that was done on those patients. So with HIV, patients who developing TB, 150 of them were those who had silicosis, 30 of them, diabetes, look at them, 2 to 4.1 of them. And then with chronic renal failure dialysis, 10 to 25 of them. So this was from the journal, Respiratory Chem Journal of the 2000 journal. The other one, they looked at it in terms of the relative risk of active disease. In terms of the diabetes one, is 3.2 compared to the HIV, which is higher, obviously, malnutrition. So all this impact in terms of your immune system. So look at it in terms of the relative risk for this patient. If you look at 1.5 to 7.8 relative risk range for this patient, it's a bit up compared to other cases like your alcohol, your active, and your indoor pollution. Now, the question is, does diabetes change the clinical presentation of a TB patient? Now, what is important is the active TB disease may present atypical with altered symptoms and signs. Now, when it comes to diabetes, you remember previously we highlighted that even with the chest X-ray, it becomes a bit of a challenge. So even with the symptoms, they are atypical. You won't have your typical coughing and loss of weight. The other thing that diabetes have in terms of the TB may progress faster in this patient, because you remember the diabetes also alters the immune system. So in terms of recovery, it affects those patients. The severity of presentations seems to be related to the degree of uncontrolled hypertension. So when you have patients who have uncontrolled diabetes, it increases the severity of the presentation of those patients. So you want to have your AGT control on those diabetic patients so that you don't have the severity of those presentations. The effects of diabetes on chest X-ray finding are inconsistent. So this we have highlighted is because that we have atypical findings on the chest X-ray with patients with diabetes. Now, the other question is that diabetes affect the response to TB treatment. So if a patient has diabetes, does it alter the TB treatment outcome? Now, what was said, which is very alarming, was that there is some evidence that diabetes prolongs smear and culture positivity at 2 to 3 months of treatment, especially if there's a poor glycemic control on this patient. So if you have a patient that is having uncontrolled diabetes, it might have an impact on the patient converting. So you might think the treatment is not working, but the impact of uncontrolled diabetes on this patient may ultimately makes the smear not to convert to negative, even the culture, because of the uncontrolled diabetes. So it has an effect on the response to treatment. Diabetes is probably associated with higher risk of hepatitis. So liver got involved, even the kidney toxicity. So they also alter that, and will have an impact in terms of treatment because some of the drugs they are metabolized on the liver and also on the kidneys. Now, also the diabetes also associated with gastrointestinal and other side effects that may overlap with TB drugs and glucose, like your vomiting, your diarrhea. So this also have an impact on that. Almost doubling of the risk of death during TB treatment among this diabetes patient, because remember, these two illnesses, they lower immune system. So you could imagine having these two together on the patient, they can lower the immune system, which increase the risk of death for that patient. And then in terms of treatment outcome also. Diabetes also increases the risk of TB treatment failure. So the fact that the patient is having diabetes, which is uncontrolled, it will increase the treatment not working accordingly. So the treatment outcome might not be good. So diabetes also increases the risk of TB treatment failure and loses to follow up. I mean, also this it could be due to a lot of drugs that the patient will be taking. So the patient could have fatigue and not come for a follow up and not treat them properly, which will also result to a treatment failure. The higher risk of TB relapses after successful anti-TB treatment. So also that is very high in terms of the relapse for those patients because of the presence of diabetes. Now, the principle of treatment when you have patients with diabetes and DRTB, it's the same criteria applied to the anti-TB regimen design. It's your short and your long regimen. The control of blood sugar is more difficult as the impact of TB treatment takes time. So those are some of the things that you need to look at that in terms of the control. But what is important is you need to make sure that you control the blood sugar, because it has an impact in terms of your conversion of your sputum on the patient, the treatment outcome. So those are the things your patient will lose to follow. The other more comorbidities, they increase in terms of risk factor, they increase the risk for your toxicity if the more comorbidities the patient has. But do not forget, the presence of diabetes and DRTB also increases renal problems. So you need to check your renal function regularly. So your creatinine to check, or your creatinine clearance to check if it doesn't decrease, especially when you have a patient with diabetes and DRTB. Now, usually behind an uncontrolled diabetic patient, there is a serious issue with adherence, which is a socioeconomic determinant of health. So if your patient is not having any controlled diabetes, they are at risk of being sick. And those patients, in terms of taking treatment, for the DRTB, it might also affect that. So you'll also have to look at in terms of the socioeconomic, in terms of patients getting some grant and all this. Do not forget diabetic primary and secondary and tertiary prevention, where you look at in terms of the diet, the treatment, the lifestyle of a patient, that will also help you in terms of the principles of treatment for this. So this was one of the journals looking at HIV and the aging. So this is looking in terms of preparing for challenges ahead. So Edward J. Mills, with a PhD, looks at this study. So by 2015, half of the US population living with HIV will be older than 50 years of age. And the ARV coverage there continues to expand worldwide. When this aging of HIV will be mirrored in developing countries, and where with HIV, we are still learning about the determinant success of art in older age group. So what happens in this instance? The HIV prevalence will double to those patients more than 50 years old in the next 30 years. So there will be what? An increased life expectancy of patients with HIV prevalence. And obviously, taking into consideration the diabetes, the cardiovascular pathology, and renal failure could complicate this management of this patient. So the presence of this might also have an impact on this life expectancy. That's what this journal was trying to look at in terms of aging and HIV positive patient. And then when you look at the comorbidities with those, they affect in terms of the life expectancy in those patients. Thank you very much.